Hi, this is Shim. It is great honor for me to present our work to the Korean Journal of Radiology. Today, I would like to talk about percutaneous metallic stent placement for palliative management of malignant biliary hilar obstruction. In patients with malignant tumor involving biliary hilum, the management is very difficult because most of the patients are not eligible for curative surgery. They have so poor prognosis that only 10% of patients can survive in 5 years. Most patients should receive palliative biliary drainage by endoscopy or PTBD. There were several controversies over detailed methods for stent placement. First of all, it is about bilateral or unilateral stenting. Some investigators insisted that unilateral stenting has advantages in patients with one main portal vein occlusion. It is based on this concept. Portal vein occlusion results in interruption of the enterohepatic circulation and produces no more bile juice and no need for drainage. Furthermore, only 25% of biliary drainage is enough for adequate palliation, and less procedure steps result in less complications. Other investigators insist that bilateral stenting can resolve cholangitis and jaundice completely and may have longer stent patency. Second controversy is about covered stent. Recently, covered stent was used to prevent tumor ingrowth, although clinical outcomes were under evaluation. The purpose of this study is to investigate the outcome of percutaneous stent placement in patients with malignant biliary hilar obstruction. During 8 years, 415 patients with malignant biliary hilar obstruction were treated with a self-expandable metal stent. Bilateral stenting was performed in 296 patients, and the unilateral stent was placed in 119 patients. All patients were resorted by use of covered or uncovered stent. As for bilateral stent, T configuration was most commonly used. Before stent placement, bismuth type and portal vein patency were evaluated by CT or MRCP. In patients with patent portal vein, PTBD was performed at low with larger drainage. After improvement of cholangitis, bilateral T-stenting was performed. If there is too acute hilar angle or too tight occlusion, contralateral PTBD was performed and Y or crisscross stenting were performed. If the patient had one-side portal vein occlusion, PTBD was performed at low with the patent portal vein. After improvement of cholangitis, unilateral stenting was performed. If cholangitis were not improved, catheter advanced into contralateral side or contralateral PTBD was performed. To compare both groups, independent sample t-test or chi-square test were used. To evaluate overall survival and stent occlusion-free survival, Kaplan-Meier and Multivariable Cox regression analysis were used. A total of 784 stents were placed in 415 patients. Temporal catheter was successfully removed in 370 patients. Long-term follow-up was achieved in 318 patients. Stent patency was preserved in about half of the patients. Technical success was achieved in all patients. Complication rate was not different in both bilateral and unilateral groups. Complication occurred more frequently in covered stent group. However, all patients recovered after appropriate management, and not related with mortality. Successful internal drainage was achieved in about 90% of patients and not different in groups. Major complications occurred in 6% of patients. Hemobiliar, requiring transcatheter embolization occurred in 4 patients. Cholecystite and spiromas were treated by percutaneous drainage. Minor complications occurred in 7% of patients and resolved by conservative management. Stent dysfunction occurred in about half of the patients. Stent occlusion-free survival was about 5 months. Overall survival time was about 7 months. The bilateral and the unilateral stent groups shows no significant difference in demographics and bismuth type. Stent occlusion rate was also not different. The Kaplan-Meier and the multivariable Cox regression analysis shows no difference in bilateral and unilateral stent groups as for overall survival and stent occlusion-free survival. The uncovered and covered stent groups shows no significant difference in both groups. Stent occlusion rate was not different. However, the cause of occlusion was significantly different. Covered stent group mainly occluded by sludge incrustation, in contrast to uncovered stent group occluded by tumor ingrowth. The Kaplan-Meier and multivariable Cox regression analysis shows no significant difference in covered and uncovered stent groups as for overall survival and stent occlusion-free survival. Multivariable Cox regression analysis revealed stent occlusion was only factor related to overall survival. It may be suggest long patient survival surpassed stent occlusion-free survival, and overall survival may be more dependent on underlying liver function. Thus, optimal biliary drainage is more important than stent type and configuration or bismuth type to prevent septic crisis and to improve the patient quality of life. As a result, stent type and configuration did not affect clinical outcomes. In conclusion, percutaneous metallic stent placement may be technically safe and effective for internal drainage in patients with malignant biliary hilar obstruction. In addition, the stent type and configuration used may not significantly affect the technical or clinical outcomes. Thank you.